clinical reasoning, excuse me, and we're talking about the differential diagnosis as well. So you've heard all of this before. This is not a new topic for you. In fact, you heard this the first week you were here, okay, when you were here for Academy for Success, because I know that one of the instructors at least did a little bit and gave you some articles, one of which is here as well in this particular lesson. So you may have read it before, you may have not. But we're going to try and make a little more sense of it today as far as what we call clinical reasoning, why it's important, and really what are the types of errors out there that we can make as far as clinical reasoning is concerned. And then we're going to dive in a little bit more into the differential diagnosis, and we're actually going to do some group work before we leave today on developing and trying to work through getting a differential diagnosis on a patient, all right? So first and foremost, what is clinical reasoning? It's what we do on every single patient that we see, okay? Every single person that we see involves having to decide what this patient needs, what this patient has, and how we're going to solve the problem, if they're presenting us with a problem, of course, okay? So it is a cognitive process, and it's a pretty complex one, okay? It's not as simple as being able to go down a list of, like a recipe. You know, if you're baking a cake, you follow a recipe and you get an end result. Well, as you and I know, you don't always get, you won't get the same result as I will, okay? So it all depends on the kind of eggs that you use, on the kind of vanilla that you buy. You know, if you buy very high quality vanilla, if you buy an organic egg or an egg that's free range, or an extra large egg versus a small egg. If you get your sugar at a very special place, if you use sugar cane versus artificial sugar, or not artificial sugar, but artificial sweetener. Oven temperatures make a big difference also. Some people like to use oil-based recipes for baking cakes. Other people use mayonnaise instead of oil. Other people use yogurt instead of oil. Applesauce instead of oil. I mean, there's just a lot that goes on. And the end product is usually a cake, okay? But it may not always taste the way that we want it to taste. And that's the same thing applies here with clinical reasoning. There are a lot of ingredients that go into a decision-making process when we're trying to decide what we're going to do with a problem that a patient basically gives us in any kind of visit. So how do we analyze that? So there's this typical cycle that we see out there. And the cycle basically looks like this. So we consider our patient's situation. We collect cues or clues. Basically, we collect all that information. That's what this course is all about. We're going to process that information as we go, okay? We identify any problems or issues that really are concerning to us. We establish a goal for our problem here. We take action on that goal. We evaluate the outcome. What is that outcome? Patient comes back for follow-up, right? What was the outcome? Did it work? Did it not work? And if it didn't, why? If it did work, great. And why did it work? Finally, reflect on the process and do a new learning. Now, one of the things that happened to PAs this year, well, in the past couple of years, is so that the NCCPA decided that as part of the recertification process, PAs needed to do a PICME project, and that's a practice improvement continuing medical education. And this part right here, this clinical reasoning cycle, really was part and built into that PICME. Well, they recently said, as far as recently as a few months ago, right after the AAPA conference, so this summer, end of the summer, they said, you know what, we changed our minds, we're no longer requiring a PICME. However, PICME is still out there, and they will give you double credit for it now, so that if you do practice improvement, you're going to get double credit for it, and so you can finish with your certification requirements a lot faster if you're getting 40 hours as opposed to 20 for that PICME activity. So what does PICME and NCCPA have to do with this particular cycle? Well, it has a lot to do with it, because part of the PICME activity is to do an analysis of what you're doing in your office, and the analysis involves this same cycle and this same circle. Now, you can read this document on your own, and you can look at all the notes that are attached there so that you can see how to describe each section of the way. But really, if you look at it also, it looks very familiar to what we also know as the scientific method, right? It's very similar to that. In fact, as we begin to develop differential diagnoses and think about possible things that our patients may have, we call those hypotheses, we start to think about our traditional scientific method. And that's really where we're going with this particular lecture. So there are different types of reasoning, and here we start talking about cognitive error, okay? And we can't have a lecture on clinical reasoning without talking about cognitive error, and I believe that your readings also do cover plenty of cognitive error, but there are a few that I want to cover for the most part. And these are the hypothetical deductive decision-making model, another model, the algorithmic decision-making model, pattern recognition, rule out worst-case scenario, exhaustive decision-making, and finally, event-driven decision-making. What are these and why should they make sense to you? Why should you care? Okay? The reason that you should care is because these are sort of the most common methods that are out there that we can use as clinicians to come up with decisions, okay? So you don't always do it in the same way and fashion every single time, okay? You may actually use data differently to arrive at your result, okay? We think of our baking a cake metaphor again. You know, I like to, when I make cupcakes, I like to cream my sugar and butter together before I start, okay? And then I put in all the other ingredients after. I think it comes with a more moist product and you get fluffier cupcake. Other people just dump everything into the mixer and mix it all at once, okay? Sort of the one bowl method, right? Other people will mix their other ingredients, their dry ingredients and their wet ingredients, and they'll do those separate and then they'll put them together at some point, one at a time. Other people will alternate those two, the dry and the wet, okay? So everybody is a little different. Again, all getting at a cake at the end of the day, but the flavor and the taste, the consistency, the texture, the moisture is all different, all right? And so we've got to think about that when we're making clinical decisions, and these are the ways that we're going to do it. So thinking about what's the difference between each one of these concepts in terms of the types of reasoning. So the hypothetical deductive model is going to be the most common out there, the one that's used the most. And here we're going to be basing our facts on a preliminary diagnosis that is made on the basis of a series of inferences. So we can think of a detective, okay, and if a detective, or if we think of Sherlock Holmes, you know, he's trying to solve a crime or trying to solve the mystery, what do? They gather clues, okay? And that's basically what the nitty-gritty of this particular form of reasoning is. We're just finding those clues. And the idea, because it is scientific method, is we're trying to find clues that will tell us you're wrong, okay? So what will falsify, all right? Remember that in scientific method, when you were studying that as an undergrad or even in high school, it was always to negate the null hypothesis or to prove or disprove the null hypothesis, okay? So that comes back to haunt us in this particular type of decision making, because what we want is we want to find clues in this method. And by clues, we mean test results or observations that we make in our physical examination, all right? Or even words that we hear in our history, which is the case today because we're only talking about history, really. So what do we find? Pertinent positives, pertinent negatives, that will negate the diagnosis, okay? That will make us change our hypothesis, all right? So if you ever hear the term working diagnosis, all right, we need to know what that means. It is an antiquated term, and we're trying to get away from using the term working diagnosis. It is still in state law in Texas, and in fact, this year, we're trying to get that out of state law. So if you come see us in March and help us with Legislative Day in Austin in March, you will hear plenty about the word working diagnosis and why we're removing it. But if you do hear it, a working diagnosis is basically what is your number one option for this patient? What do you think this person has most likely, okay? Number one on your list. This is the one to consider the best. All of your evidence points toward this particular thing. That's what we would call the working diagnosis. Everything else, so all of your alternatives to that working diagnosis is your differential diagnosis, okay? So there's a couple of things on here. So there's a statement here about premature closure, and it says that failure for us while we're using this particular method to use contradictory information to let that change our primary diagnosis, our working diagnosis, would lead to something called premature closure, okay? And we definitely want to avoid premature closure. That is what we call one type of cognitive error, all right? Meaning that I don't want to hear it. I've decided this is my diagnosis. I don't care that the patient just told me that they had a hysterectomy. I still think they're pregnant. Okay, that's still number one on my list. Working diagnosis, pregnancy. That's the reason for this amenorrhea, okay? Well, a patient just told you they had a hysterectomy and they showed you in 2010 they had a hysterectomy. They don't have a uterus, so how could they be pregnant. They don't have fallopian tubes either. They don't even have ovaries. Maybe they did a hysterectomy with oophorectomy, all right? So there's no way that they're going to be pregnant, but you're not going to change your diagnosis. That's just stuck on that, okay? That's what we call, I mean, that's an extreme example, but that's what we would call a premature closure, okay? Some others would also call it tunnel vision or target vision, tunnel vision being the one that I hear the most, okay? Tunneling or tunnel vision is also that, where we are thinking it's this, and we've got these blinders on our sides, okay, and we can't see to the side, we can't see anywhere but forward, okay? And that forward vision is just that one diagnosis that you've already decided this is what it's going to be, I'm not changing my mind, and you've got plenty of justification, but you're not willing to consider other alternatives given more information that probably falsifies your number one diagnosis, okay? So we don't want to commit cognitive errors like that would cause us to have premature closure. And or what we call tunnel vision, okay? And as we are developing our differential diagnosis, we also want to prevent that. We want to prevent tunneling and thinking it's only this set of things, all right? A mnemonic that I'm going to show you in just a minute is hopefully going to prevent you from tunneling and thinking that something could only be one thing. In fact, I'm very excited to hear what you guys think of this case study later on today, to see if people do stick with just one set of diagnoses or people think out of the box, because the whole purpose of doing a differential is to think out of the box. So remember also, and this is going to be probably the 18th time I mention it, but remember also I told you about a book called How Doctors Think by Jerome Groopman, okay, for your Christmas reading, right? Again, another reason why this is such a good read that you can do in 2 hours, remember I told you. No test questions on that, by the way, not on how doctors think. But it's all about this particular type of reasoning, okay, and missing things and getting the wrong diagnosis and arriving at the wrong diagnosis because of premature closure, okay? And the case studies that are presented in that particular book are really remarkable to really point out the fact that we can and do make mistakes when we're deciding what a patient may or may not have. Algorithmic decision making, what I also like to call recipe medicine, okay, cookbook medicine. Definitely not something that I encourage. And you know what's interesting is the past couple of days I've seen over by my office where those little couches are, by that window, on that little thing, on that little table, there are some copies from a book that I have that's algorithmic medicine, internal medicine. And you know, it's the flowcharts, okay? Flowchart, you can call this flowchart decision making if you want. Same thing, okay? Extremely dangerous type of medicine to practice, all right? It's one way of thinking of things, and I'm not saying not to use algorithms. And an algorithm is basically that, it's a flowchart, okay? It's a flow going from one thing to another to another. Now, these algorithms and these flowcharts, of course, are based on research. They're based on facts. They're often based, they have, you know, very heavily rooted and frameworked in Harrison's textbook of medicine or Cecil's or whomever. So, you know, there's definitely some science behind it. A lot of them are very evidence-based as well. So you'll find that too. The problem is that they're very strict and stringent, okay? I have nothing against the military and military medicine, but military medicine, if you talk to a PA who's been trained in the military, they're going to tell you a lot about algorithmic decision making. Okay, they're getting away from it a lot now at this point, but back in the day, you would find that military PAs, really that's what they had in common. They did a lot of algorithms. It's very common also when we get EMTs and paramedics in our programs, and they come into the PA program, sometimes on those students, it's difficult to get them out of their way of thinking because they are also trained, and as an EMT myself in the past, you know, you are trained in that discipline to do a lot of algorithms, okay, and run a lot of, you know, because ACLS and BLS, it's all about step 1, 2, 3, 4, go down the line. If this didn't work, you do this and this, shock them, give them this, give them that shot, give them the other shot, and then if it still doesn't work, they're in the ER by that time, right? And then we take over with more critical thinking type things. And they're also trying to get away from that as well. But the problem is that algorithms are too inflexible, okay? And we can't possibly apply every single algorithm, every single recipe to every single patient that's out there with a similar situation. Everyone is a little different, okay? So my warning to you is to be careful when you're using these sorts of things. I think it's okay to learn medicine and learn how to work up a patient, you know, step 1, step 2, step 3, and get an idea of what the groundwork looks like, what is the framework to use in an approach to a patient with a pulmonary problem or a patient with a critical issue, sure. And if you're doing ACLS, please abide by the ACLS protocols, okay, because that's what you have to use to save a patient in that critical issue. But when you're managing a patient overall, you don't want to use the same recipe for every patient, all right? Because everyone's a little bit different. It's not one size fits all. So pattern recognition. Pattern recognition requires experience. So none of you will be able to do much pattern recognition as a cognitive decision-making tool when you graduate from here, or even as you are students here. You will actually start the process. You'll start to see plenty of patterns, especially on those rotations where it becomes monotonous day in, day out, like on your capstone rotations, because you're at the same place for 3 months. You're going to start to see some pattern recognition there. Otherwise, throughout the rest of the year, it'll be hard to see patterns because you're only there for 4 weeks, a very short time, and it'll be difficult to see the same thing day in, day out. When you're there for 3 months, you're going to start to see really series of things like either signs or symptoms in patients that tend to be all together, complex presentations that are always, oh, all of these signs and symptoms go together, and that's all what I call a cold, or this is all what I call a migraine, all of this set of signs and symptoms. And you'll start to see some of that, okay? And as you become more and more experienced and really see a lot of medicine and a lot of cases, then you'll get better at that, okay? So one of the problems with pattern recognition, though, is that you tend to have a lot of premature closure. And here they call it anchoring. Anchoring bias refers to the tendency to rely too heavily or to anchor on one piece of information during the decision-making process. So because, and a very, 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 very close friend of mine just went through this in the medical field, and because there wasn't one symptom, which tends to be a classic symptom in a syndrome, her son was not diagnosed with the right diagnosis and almost died, like literally died one day, and is lucky to still be with us. But because the patient didn't have one symptom that is listed in the Harrison's textbooks of medicine as present in 52% of patients who have this, because he didn't have that, he didn't get the right diagnosis and therefore almost died. Huge cognitive error, because they were the providers in this case were anchoring on the fact that he didn't have this one symptom, which you have to have that to have this diagnosis. Well, in fact, no, you don't. In all of medicine, you don't have to have any diagnosis 100%, okay? Unless there is a test that says if you don't have it, then, and then there's always could be that one exception. So never say never in medicine is what I always say. And so this type of decision-making process can help. And like I said, more experienced people use it, but there's a reason that experienced clinicians use it, is because they're able to recognize a lot of the times that they may have some of this bias. So I wouldn't encourage you to use this kind of decision-making in your process because you're not experienced enough to catch your bias yet, okay? And you may actually miss something. And then there's also something called confirmation bias. And that's also called closed-mindedness, okay? Again, similar to the same situation that I told you earlier, and that is, I'm so right that I can't be wrong, okay? And I'm not going to change my mind because I've already decided that you're pregnant, and we're not moving from there. And I don't have time to think about anything else, okay? And you see this quite a bit, all right? And who do you see this from? You tend to see it from stubborn clinicians, first of all, but you also tend to see it from the more experienced people out there, okay, who really don't feel like they could be wrong, ever, okay, or that the patient's opinion doesn't matter, that theirs matters more because they have that experience. And that's where we go wrong. That's where we make a cognitive error. So that's pattern recognition. So rule out worst case scenario is another one. And so in this particular method, this one is designed to eliminate life-threatening diagnoses. And so we see this quite a bit. In fact, one way of listing your differential diagnoses, like if you have 3 options or 5 options, whichever, you can list them in order of worst case scenario, okay? Which is going to be the deadliest, which is going to kill the patient first, or life-threatening, and then we list them, we go down in terms of least life-threatening, okay? So sometimes you'll see a student, like if you run into a medical student or whatever, and you wonder, well, why isn't your differential diagnosis diagnosis listed in terms of most likely to least likely. That's another way to write it down, right? So differential diagnosis, number 1 is the most likely, which would also be your working diagnosis, and number 3 or 4 or 5 are going to be your least likely diagnoses, right? The other way to document them is which is most life-threatening to least life-threatening, all right? So if someone asks you for a differential diagnosis, ask them which one they want, okay? Which order would they like? Which decision-making process do they want you to document? Okay, it's fair to ask that question. What if they say both? More work for you, but at least it's more of a learning process, right? And so in a chart, in a medical chart, in order to document these, typically differential diagnoses are not something that we as clinicians typically document because it opens up the reader to what? To maybe I'm not right. Maybe I'm not sure what this is. It opens it up to too much ambiguity, okay? So where you see differential diagnoses documented a lot is from student notes and from student H&Ps, student write-ups. You see that because we're trying to see what your thought process is in that and making sure that you justify every one of your diagnoses in that. So that's why you don't often see the differential listed in a chart. Now, sometimes though, you will see a dictation or you'll see a chart where in the plan, the clinician has actually stated on my differential diagnosis to consider in the future plan, should I need to, would be this, that, or the other. I'm not considering those because of this part, that part, the other part, and this evidence and that evidence, okay? So they still tell you on the dictation why they negated those other diagnoses, but at least they say this was my thinking. Otherwise, should they need to come back or should they get a consult or someone else reads the note, then that can be done. So the problem with worst case scenario is that typically you're going to need very extensive workups here, okay? So patient comes in, 15-year-old male comes in with a chest pain. Worst case scenario, it's a heart attack, right? That's what's going to kill him, a heart attack. How likely is a 15-year-old healthy male going to have a heart attack? I mean, that's extremely unlikely, okay? So is it worth using the rule out worst case scenario decision-making process model for that patient there? What am I going to have to do to rule out MI on that patient? And if you just say EKG, you're wrong, okay? That's where it starts, all right? There's a multi-million-dollar workup that comes after that, okay? Am I going to do that on a 15-year-old healthy male, especially with a normal EKG? Normal EKG is not going to cost a lot. But am I going to do the rest on that male, especially with a normal EKG? Probably not, okay? Especially in the absence of risk factors, in the absence of hyperlipidemia, and all of those other common causes of MI, all right? So I'm not going to follow this particular decision-making model to make a decision on that patient. Bless you. I might go with what? The hypothetical deductive model instead. And that'll get me a better answer on that particular patient, okay? So the exhaustive decision-making, all right? This is the one that I see commonly from people, from clinicians who don't know anything, okay? From those clinicians that somehow graduated and passed their exams and got a license somehow, and yet they have no knowledge base whatsoever. They don't know what they're doing, okay? They are just practicing, and what they do is every decision they make is an exhaustive decision that they make, meaning they shotgun it, okay? When you shoot a shotgun and you have all of these pellets, what happens, okay? And I'm going to talk about sharpshooting. I'm talking about all these pellets go everywhere, right? So basically, I'm going to hit something, all right? I'm going to order every test in the book. I'm going to do every physical exam technique I know how to do. I'm going to ask every history question I know how to ask, and I'm going to hit something, okay? I'm going to try every bait I have in my tackle box, and I'm going to catch some kind of fish. I don't know what fish I'm going to catch, but I'm going to catch a fish, okay? And that's the exhaustive decision-making model, okay? Doing a shotgun approach and casting a really wide net to see what you catch. You throw a net in the ocean, what are you going to catch? Well, if there's a school of some kind of fish, hopefully you're going to catch lots of fish down there, probably all the same fish. But if there's nothing down there, I mean, it's going to be random. You might get a crab, you might get a shrimp, you'll get a fish, maybe a shark, an octopus. I mean, are you really going to get what you want? If maybe that day you want tuna, and you just throw a net randomly into the ocean, are you going to get a tuna? Chances are probably not. Or you may just out of pure chance. And your decision-making cannot be based on pure chance, okay? In fact, your decision-making ability has to be based on a better than 95% confidence interval. That's really where it's got to be at, statistically. You have to be 95% sure or better. I prefer that you be 100% sure, but that's never the case. That's impossible for any one of us to do in medicine. But you have to be at least 95% sure or better. That's what studies are. You read anything in the New England Journal of Medicine or the Journal of the American Medical Association, everything is going to be 95% or better confidence interval. So we got to make sure that we're making clinical decisions at that level as well. And this is definitely not going to be your approach. Is it used? Sure. You sometimes see it out there, especially when you've got things that are very, very vague, okay? When you have chief complaints or things going on with your patient that are just not making any sense, can't connect one thing or the other. And let me tell you how rarely that happens. That is not common. When you can't make a decision about any kind of history is not connected to itself, the history is not connected to the physical, like there's nothing out there. Those are very, very unique and very rare instances. So there's going to be a very low necessity to do this kind of shotgun approach, to order everything in the book, to do all the physical exam, all of it. Now, when you're doing a lot of history and a lot of physical, you're not doing any harm. You're just spending more time, right? So it's okay to do that. I mean, you're not going to do them harm. But when you're spending so much money, all right, so much insurance money, or your patient's paying out of their pocket to get so many tests done, or to get so many prescriptions that are not needed, then you're causing problems, okay? Not only to the system, in our systems-based practice, but also to yourself, to your patient. They may be taking things they don't need, getting exposed to radiation that they don't need to be exposed to, getting pinpricked way more many times than they need to, okay? Not to mention all the risks that come with half of the things that we do to patients when we are working them up and investigating. Event-driven decision-making. We see this a lot in urgent emergent care. So you're going to see this quite a bit on your ER rotations, surgical rotations, where especially where you're dealing with a lot of trauma that needs to be dealt with very quickly, okay? And so this is where you get a little bit of algorithm involved as well, but it's not so much algorithm as much as it is what's happening with the patient, how are they now, okay, let's do this next. As far as if you can think about like asthmatics, for instance, since you've been through the asthma deal, you know, so asthma patients, we see them, you know, when we make certain decisions, the first thing that we do for an asthma patient is what? Albuterol, right? If we're going to treat them, albuterol is typically the first step. Depending where they fall on the continuum of the guidelines, then we decide if they're going to need, which is the next step. We decide if we're going to need to add what? Corticosteroids, right? We're going to decide if we're going to need inhaled corticosteroids, right? And then from then what? Long-acting medications or not, okay? And so that continuum, but we don't move on that continuum until we know how our patient's done, right? And depending how they're done, and the decision is so complex because we use guidelines to inform that. And the guidelines for those asthmatics is a little bit tricky, right? Because you got to think about, are they having issues more than twice a week or more than once a month or twice a month or 3 times a month or more often than not or whatever. Psychiatry, same thing, DSM-5 definitions. Are they having all these problems on more days and more often than not and whatnot? I mean, there's a lot that we have to consider before we consider moving up in the continuum of the treatment care plan. And that's more than just an algorithm, okay? It's like we have to like decide what we're going to do with them based on how they've reacted to what's happened. And a traditional algorithm that goes from one block to the next doesn't really take so much into account on how the patient did in terms of all of the guidelines that are listed. Now, I've seen some pretty involved flowcharts and algorithms that will have guidelines based into them, okay? So there's some kind of synonymous relationship between this particular decision-making process and the algorithmic decision-making process, but algorithms are typically super simple and very rigid and not flexible. And here, we're talking about using an algorithm of sorts, but you have some flexibility built in there because you're waiting to see what the product is, okay? And you're reanalyzing as you go. So there is some reanalysis and reflection built into this particular decision-making process, all right? You see it a lot in the ER, specifically, so in order to make good decisions. Did you have a question, sir? I did? Okay, great. All right, I read your mind, right? Excellent. I'm glad I can do that. All right, so those are the different reasonings that are out there that I wanted to talk about today. And the other one would be remember to spit, okay? And remember to spit means this is another way that you can think about reasoning and you can think about developing your differential diagnosis, okay? So you can put them in order of what's most serious in your patient, what is most probable, what is most interesting about what we have here with our patient, and what is treatable, okay? So something to think about as you're developing your differential diagnosis here. Now, we've talked about the differential diagnosis, and it shouldn't say I vindicate P, that's an old one there. It should say just vindicate, okay? And so I want to just kind of draw your attention to this mnemonic here. Do you need to memorize this? Do you need to know every bit of detail on this? You need to know what the letters stand for and how to use it. But we're not going to practice this particular part today, but I want you to take it into account as we break up into our groups in a minute, as you're developing your differential diagnosis for today's case. So, as you're thinking about a patient who has altered mental status, like the next slide shows you. It shows you an example of how we would apply this, okay? We need to think about what sorts of things vascular-wise, what diagnoses vascular-wise would cause us to have altered mental status. What inflammatory or infectious processes could we have that would cause us to have altered mental status? What neoplasms or what cancers can cause, and where do the cancers have to be in order for them to cause altered mental status? What degenerative or deficiencies that we have, like vitamin deficiencies, or what toxins or drugs that we might take would cause us to have altered mental status? Are you getting how it's like an enormous list, okay? So you could come up with more than just 3 things, all right, or 5 things. You could come up with 1, 2, 3, 4, 5, 6, 7, 8, at minimum 9 things if you used every letter. Now, if you broke it apart and then used all the different parts of the letters, you could come up with a list of 20 things that your patient could have based on the one chief complaint they came in with, right? Now, our job, though, after developing this vindicate sort of differential diagnosis, our job is to say, well, I only want to break it down to the 3 or 5 things, 3 to 5 things. So we can do that several ways. What is most likely to least likely, like I've already said, or what is most life-threatening to least life-threatening, which is the other way. Or I could do the spit. Okay, so again, which one do they want? What is your preceptor looking for? What is your attending looking for? Your supervising physician, you ask. Also, as you begin to practice and decide for yourself how you want to practice, you decide which one you want to do. You'll find that a lot of clinicians do both. They always want to think of what's most likely and what's going to kill them first, okay? And a good example of that, or when you're dealing with some very important things that are life-threatening, like, for instance, abdominal pain in a childbearing age female whose pregnancy status is unknown, okay? I'm going to be thinking in my head that her abdominal pain is an ectopic pregnancy until I prove it otherwise, okay? Because she can die from that from here to tomorrow, okay? As opposed to if it's just a simple indigestion, she ain't going to die, right? But I want to find out first, is she pregnant or not, so that I can get ectopic pregnancy out of my head, and I know she's not going to die on me, okay? Because that's number 1 on my thing. It may not be the most likely diagnosis, okay? Because maybe she just had her period, right? Or whatever, and she's had no sex. But I don't know if I should believe her or not, right? Because I don't know if I can believe someone who tells me they're not sexually active, and, you know, I don't know them. So they could be telling me not the truth, right? So I want to find out. So as I'm practicing and I'm trying to cover my butt, you know, medical legally wise, I'm going to be thinking about both, what's most likely and what's most dangerous, okay? And I'm going to be doing a balancing act in my head as I'm considering the diagnosis that I'm going to give this patient. Doing that balancing act of, okay, positives, negatives, pros and cons. I'm a big pros and cons list person, okay? Thinking about, oh, which way am I going to go? Do I want to do this? Do I want to call it this? Do I want to call it that? Well, she's got this, but she doesn't have that. And, you know, I'm going to try to find the best balance, okay? And I'm also going to try to be realistic about the lab tests that I do, about the time that I spend with the patient, okay, and not over-exhaust and shotgun approach what I need on this patient. Am I going to get a pregnancy test? More than likely, okay, because I want to rule that out. So that's one example, okay. In a male with abdominal pain, all right, we'll say that he's 20, all right. I'm going to be thinking about, he has abdominal pain right here. I'm going to think about, you know, I'm going to think about appendix, okay. It's his appendix. It's a ruptured appendix before anything else, okay. And once I decide probably not a ruptured appendix, then I'm going to go, and remember the gold standard for appendix is what? Open them up and look at it, right? That's the gold standard, not a CT scan. So am I going to do that? Am I going to open up everybody and send them all to surgery to see if they have an appendicitis? No, I can't obviously do that. So I got to weigh all my evidence. I got to weigh all my history, all my physical, pertinent positives, pertinent negatives, every lab test that I did, put it all together to make that decision on whether or not this male is going to have appendicitis. That's going to be for his age with that particular presentation. That's going to be the most life-threatening, and right now it's going to be the most likely also, all right? Once I decide, you know what, he's got 2 out of 20 signs and symptoms of, so the evidence really is not pointing at appendicitis. I'm going to go in a different direction. I'm going to put that lower on my list. I'm not going to take it off, but I'm going to put it down lower on my list, okay, so that as I continue to examine him and I do serial exams, okay, then I'm going to start involving what? I'm going to start involving that other form of decision-making, event-driven. Then I'm going to, as I do exams every hour on this patient to see how he's doing, I'm going to start to see how he's feeling. It's going away. It's getting better without pain medication, okay? Then maybe this isn't appendicitis. So now I've used this model here to make my decision a little bit better, all right? So I'm not going to say that I will never, ever use any of these other things. Frankly, I don't use this at all. But I'm never going to say I'm not going to use any one of those others because I may, all right? So this other slide here just gives you an example, and I put altered mental status because you're doing neuro right now, so it should make a little bit of sense as you go through this. So if you have someone with AMS, you would be thinking about these things. So vascular, it could be a stroke, it could be a TIA, a subarachnoid hemorrhage. Infectious, it could be meningitis, encephalitis, it could be sepsis. It could be epilepsy, postictal state. It could be CNS lupus. It could be neurosarcoidosis. It could be a traumatic brain injury, traumatic epidural or subdural hematoma. I mean, the list goes on and on, okay? There's a large list here. And let me tell you, when we get to abdominal pain, and you have me for that module next semester, the list for abdominal pain is like 60 differentials or more, all right? GI, I'm trying to figure out how I'm going to do GI this year because I need more time. It's just you can't do it in 2 weeks. It's so much information. And I don't want everybody to get to see this year again. So we're going to try to do better. We're going to try to do better and package it a little bit. But although I wasn't here half the semester, for the half of that, I taught it and then I got sick right after that. So I'm saying it's not my fault, but anyway, I am coming up with solutions for that. But anyway, so we're going to talk a lot about differentials when we get to that because it's in the world of GI, it's all about differential diagnosis. I mean, that's where it starts. And really, that's where it should start on every module that you're doing. You should be thinking about those signs and symptoms, that chief complaint, approaching a patient with altered mental status, approaching a patient with headache, approaching a patient with seizure. You know, those are the 3 big ones. Okay, approaching a patient with dementia and or delirium, okay? Those are the main categories in neuro. There's really not much else, guys, in neuro. Neuro is not that hard, all right? It's just getting it in your head, of course. But that's really about all. In a nutshell, those are the big giant categories you got in neuro. So you got to be thinking about Vindicate for each of those, for headache, for seizure, all right, for dementia, for delirium, altered mental status, and then you're done, okay? Now, that's easier said than done, right? But we've got to put it to paper. We've got to study these things. What could it be in each of these here? And then your list becomes long and long and long. And what helps, though, because I think that Vindicate is sometimes a little too broad and a little too big, it helps students a lot because you guys don't know medicine yet and how to compartmentalize it and how to package it yet. So it really helps to do this exercise on every chief complaint you get so that you're thinking about what are the possibilities out there. But then what you want to apply after this is what's most likely, what's most life-threatening. Okay, and I don't need to go through that again. I've already gone through it. So here's the process. Okay, so we present with a complaint, and this is what I want you to do today in our little quick case study. Allow the patient to describe their presenting symptoms. We already do that. Consider 3 or more hypotheses. Okay, so based on the demographics, we're going to do that in today's case study. I'm going to give you a short, one-liner. What do you think? Just from that, chief complaint and age, patient profile. What do you think he's got? Should we do it that way? Should we profile that quickly? Should we make decisions right away like that? Absolutely you should. Okay, start training your brain to think in that direction. Now, you also need to train your brain not to tunnel and not to do that premature closure. That because you saw one word in that opening statement, this is all it can be. These 3 things, I'm not considering anything else. Okay? Well, what we do after that is we think about, well, these are the 3 things from the opening statement that I think it could be. What differentiates them? What do they have in common? What do they have different? What are you going to be expecting to hear in the history to really tell them apart? Okay, because that's your key. As you begin to ask more historical questions, so notice the 3rd block is continue with history taking. So as you begin to develop that HPI, you need to be asking questions that are going to answer what is going to separate and what's either going to prove or disprove, and more likely disprove, those 3 things that you told yourself initially, this is what it's going to be. After we finish asking those questions, those extra questions, so then we ask ourselves, so now that I know this information and I know the whole HPI, and I know the past medical history, and I know a little bit of the social history, family history, does any of that make a difference? Okay, so we reflect, we reanalyze, we reframe. Does any of this make any sense? Can I make some connections here? Okay, every question that I ask on that history, can I tag it to any one of those diagnoses I was considering? And maybe I can tag one of those questions to more than one, in which case is that helpful? Not typically, right? Because we want to be able to tag things to certain diagnoses. So then we start a process of elimination. We start being that Sherlock Holmes, collecting those clues and saying to ourselves, this clue makes sense for this diagnosis, this other clue doesn't make so much sense for that diagnosis, but it makes sense for this other one that I didn't even put on my list. So is it okay for you now to change your list? It is. So then we change our list right after that again. We say, okay, now my list is, you know what, I'm bringing in 2 from that I had initially, but that 3rd one I had initially, I'm crossing off completely. I have a pertinent positive or a pertinent negative right here that really tells me there is no way that's going to be the diagnosis. I'm taking it off the list, and I'm replacing it with this other thing. Okay? And then guess what? We're not going to talk about the rest because that's not part of this course. But then guess what? Physical exam comes into play. Then we start to do observations, and we start to look at our patient, touch our patient, and then we order lab work, okay? Then those pieces of information also go in there, and after we finish the physical exam, we tell ourselves, okay, I have all of this history, here's what I thought it was, now I did the physical, didn't find anything there on the physical that would really corroborate with the first 2, but the 3rd one is pretty strong now because the physical really is pointing toward that 3rd diagnosis I had on my list. So then guess what happens after that? You rearrange. So then number 3 becomes number 1 most likely, all right? And maybe the new number 3 is now your new number 1 life-threatening, okay? So there's a definite shift in your diagnoses. Then you move on to labs, and then you find that you have, I don't know, basophilic stippling or something, okay? Something so pathognomonic that it could be only this diagnosis. And you're like, okay, well, it's not even number 3. Now it's going to, or number 1, now it's going to be a whole different diagnosis altogether. One test like that is so specific, that is very high in sensitivity and specificity, near 100%, if not 100%. There are very few tests that have 100% sensitivity and specificity both. And when it is that sensitive and that specific, then you can say I'm diagnosing a lab. as opposed to a patient, okay? And in that case, I would say I'm changing my diagnosis. Number one is this, because this test is so good for that, and it is the gold standard, that there's no way it's going to be anything else, okay? You did a biopsy, and the biopsy showed that exact kind of cell. There's nothing else it could be. And so then your diagnosis would be definitively that, number one. But by that point, you've done so much already, okay, that, you know, doing a lab isn't the first thing that you do on a patient. And if you do, that's the exhaustive method, that shotgun method. I don't know what you have. I don't care what you have. I'm just going to do everything in my lab here, and then I'll tell you what you got right after. Okay, that's the lazy way of doing things. Okay, believe me, that method of practice is out there, especially on those offices that want to churn money and make money. Okay, those offices that are all about just ordering and ordering and ordering and ordering lab because it brings the money into the office. You're going to see a lot of shotgun approaches. Okay, so my encouragement to you is to make sure that you're very aware of the fact that you may work in a place that's asking you to do more lab than you need to. In which case, you decide. Is it worth your paycheck? You want to bring in that bonus at the end of the year? Fine. Justify the lab. That's all I'm asking you to do. Is every time that you order a lab that you think you don't need, justify it. Why did you order it? Okay? In this day and age, insurance companies won't even let you get away with that anymore. Okay? Insurance companies want you to tag everything. So, okay, you're doing a CBC. Why'd you do it? What's the diagnosis? So you actually have to submit ICD-10 codes that comply with all of the lab that you did, okay? And if you don't, guess what? You're not getting paid for that x-ray. Because why'd you do a chest x-ray? Patient has a pain in the foot. What was that for? Okay? You don't have a diagnosis for anything that involves the chest, so why would you order a chest x-ray for a foot pain? Okay? An x-ray of the foot, I understand. If your foot hurts, you know, they'll pay for that. But they're not going to pay for the chest x-ray. Well, you should know, insurance company, they have a fracture in the foot. They could have a pulmonary embolus. They could have something in the lung. I'm checking the lungs for that PE. Well, first of all, you can't see a PE on a chest x-ray typically. But second, the insurance is going to tell you, well, then why don't you put that down as a diagnosis? You know, pulmonary embolus or whatever, shortness of breath or something that would be related to that particular problem. So that's kind of the way it works. All right, so in your iTunes U, you have another document there under the annotate section that is an application exercise. I don't want you to move across the room. What I want you to do is turn around to the people behind you. So here, you guys over there might have to get a little creative because you can't turn around to anybody in the back row. So just kind of work together in small groups there. You don't need to get into your formal groups that you have. Maybe of a group of about 4 people, no more than 4 per group. There may be a couple of groups with a few people more, that's fine.